Welcome to the Psychology Talk podcast. We are your hosts, Dr. Scott Hoy, clinical psychologist,
and Kyle Miller, licensed counselor. Psychology Talk is a unique conversation about psychology around the globe. We speak with psychology experts to keep you informed about current issues and trends. We advocate toward reducing stigma and educate about mental health.
While you're listening, please take a moment to give us a review and subscribe on Apple Podcasts, Spreaker, or your favorite streaming service. It helps us to continue providing you with quality programming. And now, enjoy the episode. Hello and welcome to the Psychology Talk podcast. Today my guests are Dr. Avrim Fishkind and Dr. Bob Cuyler. Dr. Fishkind is the Medical Director of Psychiatry at Freespira, and Dr. Cuyler is the Chief Clinical Officer of Freespira. Well, hello and welcome to the show, gentlemen.
Pleased to be with you this morning.
Thanks for having us.
Okay. So, well, tell us a little bit about this Freespira device. Tell us about this.
Sure. So Freespira is an FDA-cleared prescription digital therapeutic that's indicated for treatment of panic disorder, panic attacks, and PTSD. And it really has three kind of key components to it. One is a piece of hardware, and I can go into a little more detail about the hardware, but it's a medical device that measures respiratory physiology. Specifically, it measures respiratory rate, respiratory stability, and exhaled CO2 levels. We'll get into a little bit about why CO2 is an important part of breathing physiology. And the system is used at home after a licensed healthcare professional determines that the person has the symptoms that we treat, the conditions that we treat. It's sent to the patient's home. It's used really as a lease model, a 28-day once and done treatment. It's done twice daily by the patient. And for 17 minutes each, the system basically teaches people how to breathe in a normalized fashion. To put it in a real simple kind of way, the ask for the patient is to listen to a rising and falling audio tone to pace their inhale and their exhale to that rising and falling tone. So we're teaching people how to stabilize breathing. I'll go into a little more detail about how dysregulated breathing, typically is for people with these conditions. And they get breath-to-breath feedback of their respiratory rate and their exhaled CO2 level. Their job is to stabilize their breathing and to basically adjust their air intake so that their exhaled CO2 level moves into the normal zone. And in that practice, they are essentially learning how to identify when their breathing is getting dysregulated, when it's getting fast, when they're breathing with their upper chest instead of their diaphragm, if they're holding their breath, if they're hyperventilating, which is actually surprisingly common for people just sitting around, and not just when they're having a panic episode, but just when they're sitting around. So the second component of the system is health coaching. So each person is assigned a health coach who teaches them in an initial session how and why to use the system, basically how to turn it on, how to use it, and teach them basically the principles of normalized breathing. That health coach then follows up with the person over the therapeutic month. And we get into the third part, and that is the system. A small tablet computer at the end of every session sends the session data to the company's secure server. So the health coach is able to see whether the patient did their session, whether they completed it, whether they hit their physiologic goals or targets, and whether their symptoms are changing over time. So we've got the system, the coaching, and the data analytics that are all sort of wrapped up in the delivery of this intervention.
Wow. Okay. So what I'm intrigued about is I know a number of platforms like this, similar at-home devices for anxiety and other treatment issues. They don't have a coach. And they don't look at any data necessarily. Many of them don't. So this is really exciting.
Yeah, we think that both of those are really important ingredients in the package. One, the health coaching really helps people kind of identify their goals. The health coach can even see in that first video session, oftentimes you see people with their shoulders heaving, and it's easy to tell that they're breathing with their upper chest and not with their diaphragm. We can see them struggling with shortness of breath, which is a very, very common symptom of people with panic. And then the data analytics let us know. It's kind of like, the pill of the future. So the doctor would know if you filled your prescription, if you swallowed the pill, whether it's metabolized and whether you're getting better. So all of that data analytic really is kind of baked into the system, the adherence, the physiologic data, as well as the symptom change.
Yeah. Wow. Okay. So this is really exciting. So you're saying the coach is actually coaching them through telemedicine because they're looking at whether they're doing thoracic or chest breathing versus diaphragmatic breathing, and they're coaching in that.
Right. The initial session is always done over secure video. And, there are a number of components. One is the observation. Oftentimes you're able to see sort of characteristics of the person that will help you coach. But I think it also builds the rapport for that therapeutic relationship, that coaching relationship that evolves over the course of that month.
And then the rest of it is done either through text or email or phone?
Flexibility in the follow-up. We really prefer to do, secure video wherever we can. And kind of defer to patients' choice if they need to move to phone or text. By the way, I'll mention that Dr. Fishkind is really a pioneer in telemedicine in this country. And Avram, maybe your thoughts about, kind of where this sort of intervention fits into delivery now that we're no longer bound to somebody showing up to a practitioner's office.
Yeah. So one of the most interesting things to me is that back in 2006, when I was using telemedicine, it was a highly specialized.
That was anathema back then, yeah. Or
that's
lucky to be able to use it.
Yeah, that's Jurassic age for digital technology and medicine, and so it's been quite a revolution to see it become so commonplace now. I'm glad it's a fulfillment of a dream to see it actually reach people. So, technology is interesting. We have a lot of studies showing that in the absence of a human being, live face-to-face, that you can have great outcomes. A classic example would be the crisis text line, in which people simply text back and forth and then use machine learning to figure out what kind of interventions by text actually prevent people from feeling suicidal. So one of the things that's interesting here to me, just to riff off of what Bob said, is this is a kind of for me, a perfect combination of the presence of human beings and the presence of a digital technology. I think, at least at this time in human history, people are fearful of losing the human component to treatment. So I think health coaching, which a lot of us in the profession tend to sort of downplay as déclassé or ineffective or not really part of a rigorous form of treatment, health coaching has become very common. And life coaching has become very common.
I think the majority of the psychoeducational component of psychotherapy or other like psychiatry is teachable by many people. Very simplistic. I mean, it's basic concepts that are easy to learn.
There's a great book called Persuasion and Healing written in the 1950s by Jerome Frank. And he said, it's a great book. And he was a mentor of mine at Hopkins. He basically said, look, all of us are modern day shaman. Shaman didn't have, they used the power of their voice to instill hope and persuade people to feel better. So many of us, regardless of the title after our names, can play.
Well, that's refreshing to hear that from somebody with an MD. It's very nice to hear.
Okay. My pleasure.
I kind of side with that. I very much do side with that kind of approach of, meta perspective of what healers do. But so the Teletherapy platform is there, and you've been involved with it. You've been championing the Teletherapy platform and telehealth for years, it sounds like.
I have. It's when I was in training, all I ever heard was psychiatrists are never available. We're never there where we're needed. You have to wait 3 months to see one. So it was just part of my philosophy of actually putting that all down, putting that to rest, was so that we could be where we were needed at the right time that we were needed. And that, I think, is fulfilling our real mission. And I think that's really put a rest to some of those complaints.
Yeah. Well, maybe you can speak a little bit about the science of capnometry and the CO2 element that's involved in this device.
Yeah, so it's a great question about where it comes from. To give a little bit of a bracketing of this, of this treatment, panic and PTSD are traditionally treated with psychotherapies, particularly exposure-based therapies, or with psychotropic medications. And so to create an intervention that drives a different highway is really quite intriguing. And really where it came from was from work that really kind of got started in the early 1990s that looked at what really kind of differentiates panic-related conditions from the rest of mental health disorders. And one of the real important characteristics was dysfunctional breathing. And really kind of for me, the guru of where this intervention came from is a psychiatrist named Donald Klein, who died about 2 years ago, who first introduced the notion that respiratory style in at-risk individuals created a kind of dysfunctional breathing. And to put it in a very oversimplified fashion, his theory was that for some reasons kind of known and unknown, a portion of the population is hypersensitive to respiratory distress, to sensations of air hunger, shortness of breath, and their compensation, unfortunately, creates a dysfunctional breathing style that kind of sets the stage for symptom triggers. And really an evolving kind of science and practice out of that kind of gets to the origin story of the intervention that we do. There's a group out of Stanford who really kind of asked an elegant question, and that is, if dysfunctional breathing that includes CO2 physiology is in the mix, what would happen if you taught people how to normalize their breathing? So there was work that was done out of this Stanford group that was done essentially with kind of laboratory grade equipment done in clinical trials, and taught people how to pace their breathing and how to, by providing feedback of their exhaled CO2 level on a breath-to-breath level, teaching people how to adjust their respiratory volume so that they normalize. And really out of that interesting sort of conceptualization came just striking clinical results. People with long-standing panic conditions getting better in 28 days and remaining better a year later. That's what caught my attention when I was introduced to this intervention almost 8 years ago. And there were really two things there. One is I had an opportunity to kind of read the science, and it was intriguing to me because as a psychologist, I'd thought really about dysfunctional cognition as really kind of the core of panic-related conditions. And, from Avram's side of the field, neurotransmitters. So you have talk therapy and you have meds. And so it was this intriguing literature and this initial research that showed these really striking outcomes. And then I had the opportunity, several of my patients were willing to be guinea pigs. And my very first patient who was having nocturnal panic attacks. So you wake up in the middle of the night in sheer terror. You don't get back to sleep. Every night you're wondering whether you're going to fall asleep and be able to sleep through the night without this, this nocturnal panic attack where people, wake up breathing with, heaving chest, shortness of breath, heart racing, all this kind of stuff. And my very first patient essentially was well in 2.5 weeks. And I have to tell you, I consider myself an experienced psychotherapist and psychologist. I have never gotten a patient like that well in 2.5 weeks. By 28 days, he was basically done. The neurologist that referred him to me 2 years post-treatment was telling me that he continued to be panic-free. So, for me, it was this combination of some initial really almost jaw-dropping successes with patients, even before I had an affiliation with the company, and science that made sense.
So tons of questions, really interesting stuff, the Stanford study and the background in this. But so you were using a Freespira device with the patient, right?
Yes.
Okay. I told you before we started the actual show part of the show. I have experience working at the Shirley Ryan Ability Lab. It's also was known as the Rehabilitation Institute of Chicago, doing biofeedback in their pain management program. And I mean, they have a great biofeedback program within the pain management program. I'm just curious because I know about other modalities, and I was trained in heart rate variability or HRV biofeedback. So my question is that HRV biofeedback typically relies on a lot of diaphragmatic breathing, but it's not looking at CO2. So it might not be looking at the quality of breath from a truly internal, granular kind of physiological element. So maybe that's missing from it. You can get good results with HRV biofeedback. I'm not knocking that. But
sure.
I'm curious as to like the difference between those two, and any difference in this in the studies results. The efficacy and the follow-up with between those two. Have they been studied? Have they put as the test? Have they been tested side by side? I guess.
Yeah. So one of the things, diaphragmatic breathing is part of, centuries, if not millennia of breathing techniques. And diaphragmatic breathing is really the way we're intended to breathe. And for most of the population, really any kind of meditative diaphragmatic breathing is probably going to be good for you. It's about 10% of the population that we think are really kind of at risk. There's some fascinating, the epidemiological, genetic, and physiologic literature suggests that there's a portion of the population that are really perhaps wired a little bit. There's still a lot yet to learn about that. But one of the things that's characteristic of these at-risk clinical populations is that people tend to overbreathe when they do diaphragmatic breathing. And what we see is that they have exhaled CO2 levels that are profoundly below normal for a significant portion of the people who do this. And there's reason to believe that if you have vulnerability, that this sort of establishes a very brittle biological homeostasis that's easily tripped into actual panic symptoms. Most people don't recognize that, that if you overbreathe, if you do this deep diaphragmatic breathing while you're sitting comfortably in a chair, you're going to start feeling a little dizzy.
Absolutely.
Paradoxically, you start to feel a little short of breath. So you begin to have these physiological squiggles, whether you're breathing too much or breathing too little. And this is a population of people that are overly sensitive to bodily sensations, and they catastrophize those bodily sensations. And so for most of us, we can ignore a sensation of a little skipped heartbeat. For people who are panic prone, that little sensation of a skipped heartbeat becomes, oh my God, I'm having a heart attack. And they begin to breathe with their upper chest. They get sweaty, they get tremulous, they get dizzy, their heart starts to race more. And then, oh my God, I'm off to the emergency room again.
Correct, because one of the main criteria for panic disorder is fear of having another panic attack, right?
Yeah. As well as all of the physiologic symptoms. Yeah.
Yeah. And those things, any little thing can set them off. So I have done biofeedback, HRV biofeedback with people who initially were skeptical because they do have a proclivity to panic disorder, and it kind of, threw them off initially. It takes a little bit more moving them, adjusting them to it and telling them not to overdo it and to focus. Yeah, it's difficult. But with the CO2, the capnometry, it's different. And so what does that do to regulate and reduce the tendency to overdo it?
Okay. Well, one is you're actually getting feedback of your CO2 levels. And your job is to adjust your air intake to normalize your CO2. And that's what really kind of distinguishes this breathing modality from other breathing modalities.
Gotcha.
And it's very interesting. You asked about whether there was sort of a head-to-head comparison. There really has not been. But what's fascinating in the literature, there was a study that came out of the UK that had a very elegant gamified breathing game. Looks a lot cooler than Freespira in terms of the interface, but there was no capnometry involved. There's no breath-to-breath feedback of CO2 levels. And what was interesting is that this intervention had absolutely no impact on panic symptoms in a waitlist control design, which was interesting. The same research design as the original Stanford study. By comparison, there have been 3 studies that have 10-point reductions in the panic disorder severity scale after a month. This study that lacked the capnometry had a 1/10 of 1 point reduction, basically no change. And so,
Right, yeah.
We don't want to go too far with one apple and orange comparison of studies, but it is striking that something that was a very well-articulated breathing technique had no impact on panic symptoms, lacking that feedback of capnometry. One other thing I'll just kind of mention here is that most of us are really pretty oblivious to our breathing styles. And what's so fascinating is we start training people, they say, I didn't realize it, but I hold my breath all the time. Or I'm now aware that I'm breathing with my upper chest and my upper chest is heaving to the point that my shoulder and neck gets tight. And I didn't really realize if I was in a triggering situation, whether it's panic or PTSD, let's say panic person afraid of driving on the freeway and they're, 18-wheeler tailgating and all of a sudden they feel their breath quicken and their heart start to race, that people develop kind of a bodily awareness, but they're also developing a positive skill that helps them to substitute healthy breathing for the panic escalation that typically is, what they've lived with.
Well, okay. So as we dive deep into this biological aspect of the biopsychosocial model, if you will, it's a very powerful way to kind of help turn around and change or reduce or knock out anxiety symptoms by replacing just this very good style of breathing, proper breathing, teaching people. We're not born with a user's manual for this thing called our breathing and a number of other things. And our parents certainly don't think about it. Even we who are aware of breathing because we teach people, diaphragmatic breathing or use biofeedback devices or whatnot. Most of the time, it's supposed to be a background thing, right? If you had to constantly be aware of it, it wouldn't be very efficient. There's other things you can be working on as a biological entity in a person, right? And be focused on. But it's nice to be able to tune back into that. I'm curious, is the style of breathing focused on nasal breathing or mouth breathing?
Nasal
breathing. And tell me
really for a couple of reasons.
I think I know why, but tell me why.
Well, one, very pragmatic. In order to measure breath-to-breath CO2, you need to breathe through a nasal cannula. Mm-hmm. All right?
Yeah.
So, that's the instrumentation that requires nasal breathing. Now, there are some breathing traditions that say you breathe through your nose, exhale through your mouth. Ours, in order to be able to measure the breathing, you have to do nasal breathing exclusively. But there's a fascinating kind of a growing awareness that mouth breathing is part of dysfunctional breathing, and teaching people how to breathe comfortably at rest through their nose. We haven't measured whether if we were able to get the physiologic feedback with mouth breathing is, whether we would have the same results or not. We don't know.
Yeah. The reason I asked that is because when I was at Shirley Ryan, the head biofeedback therapist was using a capnometry device, and we were experimenting with it, thinking about using it as part of the arsenal of biofeedback devices there. And I would joke around and say, Felix, how's the CPAP machine going for you? Because he was testing it out for us. And it is not CPAP, it is capnometry. He would always tell me. But he also did inform me about nasal breathing. And he's like, if you breathe, nasal breathing even while you're exercising is better for you. Tell me why he said that. Was he making that up? I'm not disparaging Felix at all, but was he? Why would it be better to breathe through your nose while you're while you're using a rowing machine or on a treadmill or jogging? right. So we're stretching ourselves a bit here. So
yeah,
we can hypothesize maybe.
Yeah, there's a really popular book that came out called Breath about a year ago, and the author of that book, really one of the things, the author of the book, working with somebody who was a specialist, they made a bargain, and that was basically sealed off their nostrils, and they said your job is to breathe only through your mouth for about 2 weeks. And what they found is that blood pressure went up, sleep quality went down. Person felt ragged, exhausted all the time. I'm not sure that we're in full science here, but it was a fascinating, popular book that really kind of emphasized the downside of mouth breathing.
So just breathing through your mouth is not good for you, rather than, yeah, okay. Even though there is no big end randomized control trial of mouth breathers versus nasal breathers. Right. Okay. All right. So there is some evidence behind that. Okay. Okay. Tell me a little bit more about any contraindications for this device, using this device.
Yeah, there are a couple. One is pregnancy, and for a couple of reasons. One is any time you present data to the FDA when you're looking at FDA clearance, if you've not been tested for safety in pregnancy is really a contraindication. The other thing is that respiratory physiology in the last trimester really kind of changes. And so CO2 levels change during pregnancy. So that's just a standard contraindication for us. One is baby is taking up a whole bunch of room and compressing the lungs. And so I really had not been aware of that. But mom's respiratory physiology is, is changing, particularly in the
baby bump can get pretty big and take up a lot of space. Yeah. So the diaphragm is compromised.
Yeah. The other is advanced lung disease like stage 3, stage 4 COPD, where people cannot move CO2 out of their system. In late stage COPD, you have very, very high, abnormally high CO2 levels. And our intervention is really aimed at increasing CO2 levels, in people with normal lungs. We're also really not a good fit for somebody who is in acute psychiatric crisis.
Okay, that would make sense, yeah.
It's a use at home. You need to devote 40 minutes a day doing the practice. And we're really not meant as an urgent intervention. It's really not aimed at interrupting panic symptoms in process, but to teach normalized breathing and self-management skills.
Okay. So we mentioned panic disorder, but it seems like PTSD is something else which can have a component of panic attacks to it, right? What other generalized anxiety seems like it would be something to be helpful for, but what else?
Well, those are great questions. One is, as a company, we have to stay within our indications.
Correct.
And so we are focused on panic disorder. Part of our FDA clearance includes people who have panic attacks. And so people who have panic attacks in association with social anxiety disorder, GAD with panic attacks. There's no good reason to believe that somebody with OCD would benefit from this. Basically, the wiring and the genetics are different enough. But we are launching a trial.
I would imagine somebody with OCD would have a proclivity to want to use it in a rather obsessive way, perhaps. Yeah,
And we really think that the respiratory physiology and brain wiring is distinct enough with OCD that it's really just kind of not in the mix.
I'm sorry, you said you were in a study?
So one thing that's fascinating about PTSD is about where you look in the literature, 60 to 75% of people with PTSD have panic symptoms as part of their PTSD complex. And there's also some really interesting connections about what's called a bidirectional relationship between panic and PTSD. So we see the significant overlap between the conditions, which is why when the company really kind of started to look at other indications that PTSD was the logical next condition. I'd like to kind of bring Avram in here. So as a practicing psychiatrist and an emergency psychiatrist, there's some real limitations in pharmacology and psychotherapy for PTSD, and wondered if you could talk a little bit, Avram, about some of the gaps in care that you see as a psychiatrist.
Sure. I'll hit everybody's favorite discussion, which is medication. So I'll start with one of the biggest problem with medications. I mean, let me first, for setting the record straight to the audience, medications have a role in what we do. There are times when they save people's lives. Often they are used as an adjunct to psychosocial wellness interventions that serves a very critical role. So I just want to state that so that it's clear that I think it has a place. One of the greatest problems with our medications is that they can mimic or cause or apparently, quote unquote, worsen symptoms of panic and PTSD. So, for example, if you take antidepressants, some of them cause GI distress. They can cause what's called anticholinergic system side effects, in which a patient gets a rapid heart rate. They may develop arrhythmias and pounding in their chest, confusion, blurred vision, dizziness. So if you take these as side effects, they're also core symptoms of panic and anxiety. So when you hear patients say, you know what, I took this medicine and it worsened my symptoms, that's often what they're talking about. In common medications like serotonin reuptake inhibitors, Prozac, Zoloft, Paxil, they increase the amount of serotonin. Serotonin is going to cause a surge like norepinephrine would. Your adrenal glands are going to clamp down, spit out norepinephrines, and then you'll get a panic response. So a lot of our problems with our medications, whether they're stimulating norepinephrine or serotonin in the brain, are going to mimic, at least early on in treatment, more panic and panic symptoms. So that's the first problem. A lot of people who can't tolerate antidepressants, it's because they have these symptoms up front. So that's one issue. The other issue with medications are the benzodiazepines. Now, Ativan, Xanax, Valium, the strange part about these medications is they're amongst the most effective medications that we have in all of medicine. You give somebody a benzodiazepine, their anxiety is going to decrease. At least their subjective understanding of their anxiety is going to decrease. So we have this 90 to 95% effective intervention that unfortunately does two things. One is it shortcuts the long-term advantage of psychological, social, and wellness interventions on anxiety and pretends that those don't exist. And the second thing, of course, is addiction. And this is particularly troublesome with Xanax. Very few people, Xanax gets into your system very fast and then exit your system very, very fast. That is the prerequisite for addiction. It's also the prerequisite for causing yourself more trouble, because as you get this roller coaster effect where you get this high and you come over the hill and you have negative gravity and you're feeling wonderful, then you get the inevitable collapse as you come off.
Yeah, and I've had patients. When I worked in drug and alcohol facilities that in MISA units where obviously they were trying to get off of things like Xanax, but then I've had patients who have a proclivity for addiction, and the doctor doesn't really look into that, and there they are. Here's to feeling good all the time.
Yeah, they're off to the races. Yeah,
it is problem.
When you look at epidemiology, about 25% of patients with panic disorder and PTSD have comorbid substance abuse, so it's a high risk population. Yeah. And although the concept is a little controversial in the addiction field, I think there's reason to believe that there are a lot of people who are self-medicating with substances. We see that as a real issue with PTSD as well, where people who are, really plagued by sleep disturbance and traumatic nightmares who drink to put themselves to sleep, and it's a very dysfunctional way to manage symptoms.
Yeah, and I think it's just, with even though I'm not against it, the introduction of recreational cannabis, marijuana is probably you're going to see people turning to that to get away from alcohol or other substances. But then again, in the long run, probably getting addicted to cannabis or,
well, and then another wrinkle there is that one of the side effects of cannabis are panic symptoms. And so so for this particular population, there is a real risk. And to some extent, it's sort of politically incorrect for us practitioners to caution people about cannabis use because it's sort of been blessed now as, the wellness option. But there's a real clear literature that cannabis can be panic provoking.
I think that yes. And now it's like, it's so strong, it's like drinking space meat and you're on Pluto, like in the next second sometimes, and panicking. I think that eventually people will be able to maybe control it for less of those symptoms, but still, it's not going to help. And the best option would be to have some kind of biological regulation, self-regulation, I think, such as Freespira, right? Your device.
Yeah.
Anything you put in your system that affects your brain. One of the things about cannabis I've noticed is, most people don't know what kind of doses work, or that there are different parts of flower.
Correct.
That depending on how you combust it or what temperature, we don't know enough about a lot of those things to really, in an educated way, tell our patients.
Yeah. Well, maybe there'll be a lot more research with it in labs to kind of suss out or synthesize certain parts of it for medicines, where you can kind of control the amount. Well, okay, so we talked about contraindications. And I know that you sent a few studies that have been done, which look great. You could speak about those if you would like, or you could.
Well, one of the things that's been really interesting when we look at the different research projects that have been done with panic is that the pattern of results are so similar, and that is, a change within 28 days for people with long-standing panic disorder. In the 3 different studies that have been published, the average enrollee had a 10-year plus history of panic disorder, and their panic disorder severity scale, which is kind of the gold standard, self-report measure, has basically gone from moderately severe to really near remission level in 3 different studies, all completely independent of one another. Another study done by the Palo Alto VA, interestingly open to veterans and civilians. These folks had a 19-year history of diagnosed PTSD. Wow. And over 80% of the participants 6 months post-treatment had a clinically significant reduction in the CAPS-5, which is the clinician-administered gold standard PTSD measure. And 50% of the study participants no longer met criteria for a diagnosis of PTSD based on clinician interview as well as their CAP scores. So that's another thing that was really, interesting to me in terms of when you look at the research in sort of in a more global sense, and that is, rapid symptom reduction and maintenance of that symptom reduction out to 6 months and a year post-treatment.
Wow. Okay. That's pretty amazing. What does it say about the etiology of PTSD, the biological component? What do you 2 gentlemen think about that?
Avram, you want to start on that?
So, a lot of what happens in PTSD is obviously derived from exposure. We're not very conversant at this point about the autonomic nervous system. You were talking before. It's not conscious to us because it's not supposed to be. You can't pay attention to all stimuli all the time. If I tell you to be aware of the pressure of your butt in your chair right now, it's probably all you can think about. It's probably good that that's weeded out. Anyway, back to exposure. So we assume that because exposure sets up these processes which don't work well in our autonomic nervous system, that a treatment for those kind of things must be equally as long to be effective. There is this assumption somehow that Yeah, I equate this to the idea of doing an intervention upstream versus downstream. You can downstream work on 100 different pieces of a process that are wrong, or you can attack things upstream so that the processes down the line never occur. There's something about this treatment that is an upstream intervention. Somehow doing something at a certain level prevents all of the different causes at the bottom. We rush to find explanations for this because we cognitively try to explain everything to ourselves. I think there are ways of intercepting and doing interventions that create an upstream solution to many, many different downstream problems.
Well, so you're talking about top-down and bottom-up processing, essentially. So it's bottom-up. It's the physiology, but a lot of social cognitive and social psych explanations for how we attribute to our emotions, bodily states, or we attribute something, a meaning to them. But keeping that in mind, with your coaching element to this, I assume that they would be working on some of that psychosocial issue, right? The meaning of it. Yeah. But you're also do you recommend follow-up? So, for instance, like in the Johns Hopkins studies and the USOMA studies of psychedelics, which I'm sure that you're probably aware of, it's mostly integration of the experience of having a medicalized dose of psilocybin, for instance. And it's the integration. And they recommend highly the person go to somebody outside of that particular 8 to 15 session period of psychotherapy and continue integrating what's happened. Do you recommend more integration of the meaning of what's happened to them after this, or is it not necessary?
It varies considerably from patient to patient. And people have complex lives. When you were asking about, like where does PTSD come? PTSD is complicated, and by no means it is respiratory physiology the explanation for PTSD. So one thing that we know, even in military populations, only a minority of people exposed to intense combat trauma develop PTSD. So traumatic exposure doesn't equal PTSD. So the way that I digest the literature, there is, in all likelihood, some physiologic, genetic, neurological vulnerability. There is traumatic exposure, and there's development. And so what you often see is all three of these threads, so that you see people who have had early childhood loss and exposure to trauma, but not at the threshold of causing PTSD, who then have a traumatic exposure and who have, unfortunately, the at-risk genetics and physiology that then all come together and create this clinical condition. So Freespira is really intervening at the skill building and respiratory physiology. Now, what's really interesting in the clinical trials, people could not be in concurrent psychotherapy. If they were taking medication, the doc and patient had to agree to keep their medication stable. And so those 12-month outcomes were for people who were not in psychotherapy. Wow. Now, some of our patients, basically, they say, look, I'm no longer focused on when I'm going to have my next panic attack, and I can use therapy to focus on the rest of my life. My healthy breathing is not going to solve my marital problems, right? So what we hear from some of our referring therapists, and interestingly with some of our trauma therapists, is that as people become less preoccupied with their bodily hypersensitivity and reactivity, they are more able to process the trauma and how that trauma has kind of transformed, unfortunately damaged their lives. So some of our referring therapists basically say that a good solid month of Freespira helps create a better therapy patient, more able to consume and process therapy. For other folks, they say, hey, doc, I'm done. I'm better. I'll call you if I need you. And it really kind of varies across the board.
So the cast is off and I'm a free bird, free agent, so to speak. Yeah.
Sometimes. Yeah.
Okay.
If you're not, as Bob said, if you're not focusing on bodily symptoms, it sure opens up a lot of free space in your mind to think about other things. That one of the really difficult things for people with PTSD is a sense of foreshortened future. Part of that sense of foreshortened future is they're concentrating on their bodily symptoms. It's hard to really plan or think of yourself as somebody else or doing something different if that's all you can do every minute of the day. Okay.
Correct. Yeah. So follow-up is optional. You probably recommend it to those who want it and those who don't want it with psychotherapy afterwards. Yeah.
There are a couple of things that we also have. So once somebody has learned how to regulate their breathing, it's kind of like they can take the training wheels off the bicycle, but we provide them, our alumni, with an app so that they can say, I want to breathe at 6 respirations per minute for 2 minutes. And so that can be on their phone. That can be their sort of refresher to kind of anchor that skill. But they have learned how to regulate their respiratory volumes. So they're no longer hyperventilating. They're no longer doing that upper respiratory. So we can have this, this app that guides healthy breathing. We are starting really as we speak to do, extended follow-ups for people who have graduated to, really kind of begin to measure better whether the symptom reduction is maintaining.
Here's a kind of granular question. I know that the general sense in HRV biofeedback is, you mentioned that there's a sweet spot, which is generally about 6 breaths per minute, 5 seconds in, 5 seconds out, or some permutation of it. Is that generally what you see with Freespira, or is it varied?
Yeah. Great question. Really, there are 4 different breathing rates, and most people with panic start with rapid irregular breathing. So we start them at 13 respirations per minute. Respiratory rate varies across the 4 weeks, and it ends with 6 respirations per minute, which can be really quite a challenge. That's kind of like the graduate week of maintaining respiratory stability at 6 respirations per minute. And it's so interesting that so many other breathing traditions end up with that sweet spot at around 6.
Well, I think with HRV, that's sweet spot for coherence between the heart rate, the interbeat variability, the heart rate variability, and breath in and breath out, which they kind of connect to autonomic nervous system, basically vagal stimulus, right? Vagus nerve stimulus, but. Well, how much of the ANS do you incorporate into the psychotherapeutic or the coaching, the kind of psychoeducational coaching? How much do you discuss that with the patient?
Our coaches really stay pretty focused, basically just on following the protocol,
okay.
And really trying to ease people's apprehension. So it's not unusual in the early stage that people really react with fear because they have a sensation of air hunger or shortness of breath. So what we really try to do is to normalize and to say, this is something that you may experience in your early sessions, but treat it like you've done a brisk walk around the block, right? You're liable to feel a little shortness of breath. And that's a signal that you've exercised, not that you're in danger. So this is where there's that kind of a cognitive retraining of learn to befriend your body, learn to tolerate those aspects of bodily distress, and build new skills that are gonna help you manage going forward.
Okay. Well, is there anything else that we might not have covered that you two would want to express?
I think the only thing other that I would add that we hadn't really touched on is that what's also so characteristic of panic and PTSD is that people begin avoiding life. They avoid situations that they feel are triggering. What we hear from our patients is as they begin to feel in control, they can go out and experiment with life again. So we hear from people, I drove to the store by myself for the first time in 2 years, and it was okay, and I'm going to try it again. So we get people kind of expanding their life that had been really contracted by their avoidance symptoms.
Wow. Okay. So it can be very freeing experience using this device. Yeah. Okay. Well, how can people access this as a consumer, as we say in the business these days?
So one thing is look at our website, freespira.com. We have insurance coverage in several areas. We're covered by Highmark Health in the Pennsylvania, Delaware region. We are covered by Children's Community Health Plan, which is a Medicaid managed care plan in Wisconsin. We are on the schedule as an approved treatment in the VA. We're working furiously to expand that treatment option. We do have a self-pay option. So people can go on our website. We can, if somebody is not in therapy at this point, we can pair them with a clinical assessor who can determine that they have the symptoms.
Is it CMS approved yet, or is it just FDA cleared at this point?
Well, actually, the terminology is a device can only be cleared, not approved. So so we are at basically the highest level of FDA recognition that you can for something that's a device and not a med.
And so people could try to establish using it through billing procedures with their insurance, right? Yeah, so CMS.
Or we do have self-pay options also.
Okay. And what about clinicians who want to start doing evaluations for people who are interested in using this as an at-home device?
They can go to our website and there's a lot that they can learn just by looking at the website. I often do clinician training and teaching for people who are interested in incorporating into their practice. And they can do a simple authorization via the web portal. If they say, this patient is known to me, they're not pregnant, they don't have a lung disease, and they've got panic or PTSD symptoms. So they can do a very simple kind of like authorization through our portal.
And that would be anybody who's a behavioral health specialist, as well as psychiatrists, nurse practitioners?
Or primary care, yeah.
Primary care.
Yeah.
Okay.
And the other thing about that connection is that we communicate with referring clinicians so they get an end of treatment report that lets them know patient's been treated, this is their adherence patterns, this is the kind of change in their physiologic state, and this is their percent symptom reduction, awesome, as well as qualitative notes from our coaches.
Is there any certification that someone such as myself or a social worker or LCPC counselor would need in order to prescribe? Okay.
No, really, it's the health coaching, which is done by a team that I supervise. So practitioners can basically just refer, and then we teach and train and follow the patient so that we're not impinging on your workflow in your office, and then we keep you posted on how your patient's doing. Excellent.
Well, that sounds like a very good setup. Very convenient, and it looks like a very helpful device. Well, thank you two gentlemen for being on the podcast. I think we can probably wrap up. Well, thank you so much. And where can people find the Freespira device?
Best place is to go take a look at our website, freespira.com, freespira.com, and we'll tell you the story and, introduce you, give you information and education to determine if this would be an option for you.
All right. Thank you so much for being here. Have a great rest of your day.
Thank you.
You too.
Bye.
Thank you for listening to the Psychology Talk podcast. Did you know you can find us on the web all over the place? Well, maybe not all over the place, but you can find us on Instagram, you can find us on Facebook, you can find us at Spreaker, Stitcher, Apple Podcasts, loads of places. Please look for us, and if you can, subscribe, like us, leave us a review, send us a comment, a criticism. Hey, we like to hear a lot from people. Go ahead, talk to us. That's why we're here. By the way, this is just a reminder to let you know that all of the material here is for entertainment and informative purposes only. If you do need a therapist or a mental health professional, please seek one out. Music is provided by the band Serenati.